The American Board of Otolaryngology Head and Neck Surgery. Since 1924, the board has upheld the highest standards for the specialty. It does this work with one purpose in mind: serving the public.
Although we have many stakeholders that we consider in making our decisions, ultimately the decisions are driven by what the board feels is best for the public.
Everything comes back to providing the best care for the public. We all want the best for our patients.
Ultimately, the board is trying to make sure that physicians who take care of patients are qualified, competent, and professional.
So in some ways, we serve as standard bearers for our profession that allows people to see an otolaryngologist, and if they see that they're board certified, that they know that those otolaryngologists meet a standard.
Otolaryngology was the second specialty to take the bold step of starting a board. Along with ophthalmology, it was also among the first specialties to emerge, thanks to three technologies pioneered in the 19th century.
The ophthalmoscope was critical to advancing the management of eye disease. Similarly, the otoscope, so that one could look in the ear, and the laryngeal mirror, so that one could examine the larynx, allowed doctors to see something that couldn't be done in any other part of the body.
Those days, eye, ear, nose, and throat was one specialty. So you were a double ENT, and it wasn't very sophisticated. You would perhaps refract people for glasses, take out some tonsils, straighten some septums so they could breathe, drain some ears that were infected.
But there was no standard for graduate medical education, and just about anyone could call themselves a specialist.
You could go do a week or two with some specialist and then hang out your shingle as being a ear, nose, and toe doctor. The people that did that didn't have good results with their patients and gave a bad name to the specialty as a whole.
I think it does make logical sense that if the profession didn't start regulation of the specialty care, the public would have demanded others to come in to start doing it.
In 1916, ophthalmology led the charge, forming the American Board of Ophthalmic Examinations. Then, 8 years later, on November 10, 1924, the American Board of Otolaryngology was formally organized in Chicago.
The ophthalmologists and the otolaryngologists, really as two of the very early specialties, took the lead, basically specifying the regulation of specialty care should be done by physicians, for physicians, and for the public. That concept is something referred to as professional self-regulation.
It's really based on an unwritten societal contract that basically says that society will give us the ability to be autonomous, to set our own standards for competence. In turn, what we promise society is competence, morality, and practice, that we provide a service that benefits society, and there's altruism.
I think everyone would agree that physicians are the best ones to determine the quality of another physician's work, not a bureaucrat. And any organized profession has a responsibility to self-govern, otherwise it's not a profession.
With time, the specialty began to grow and evolve.
In the 1950s, the specialty was expanding into head and neck surgery and facial plastic surgery and other areas, and clearly showing that it provided excellent care for patients.
By the 70s, most of that work was being done in the otolaryngology profession, and they felt that the name of the specialty should reflect that.
Despite repeated attempts to change the board's name in the 1980s, the name still did not include head and neck surgery.
I think it was important to have our name reflect what we really did as a trainee, how you were trained, what you were trained in, and what was the breadth of the specialty that you were being certified in.
Finally, in 2018, the American Board of Medical Specialties approved the change.
I think it's just more accurate of what otolaryngologists and head and neck surgeons do today. I think there's a public-facing piece to the patients, so that patients understand when they're seeing a physician, they feel comfortable that their certification and the name reflects the disease process that they're seeing you for. But it's also to let your colleagues know, what do we do? How can we help? When you consult us, what expertise should we provide you?
For its first 78 years, the board issued certificates that had no expiration dates. But in 2002, the ABMS required its member boards to institute a maintenance of certification program.
To be a physician now, the data changes, the evidence changes, and what we do to be contemporary is rapidly changing. So it's important for us to know that to be an effective, safe, competent physician over your lifespan, you have to continue learning.
How would you feel if you got on an airplane? You assume that the pilot did not do their last assessment that they know how to fly a plane 20 years ago.
Continuing certification initially took the form of an every 10-year, point-in-time, high-stakes exam.
I think most people in any profession, students, even in high school, nobody likes taking standardized exams. And when you have a standardized exam that you take every 10 years, that if you fail it, you could lose your certification, that's pretty scary, you know? And so we moved to this more continuing certification program using CertLink.
CertLink is geared toward what we call walking around knowledge, which we would expect our colleagues in our discipline, it's something that they need to know to practice. So they have 5 minutes to answer every question. It's seamless to use, and you get immediate feedback on your answer.
People are continually responding to questions. They understand when they get questions wrong. They can see a critique and references.
This could be done at your leisure. It's kind of fun for me to do these questions, and I don't get them all right. And the ones I don't get right, I try to figure out why I didn't.
I really enjoy doing it. It's kind of like working the crossword puzzle. I'm about to give up my sub-certification since I'm retired, and I'm going to miss doing CertLink.
As otolaryngology became ever more subspecialized, there were calls on the board to recognize the highly specialized skills of its diplomates.
For example, pediatric otolaryngology heavily invested in deaf children, cochlear implants, children with complex airway problems, complex airway reconstruction, very sophisticated body of knowledge in medicine, which really requires that we're checking as best we can on the competencies of the people who say they are X, Y, or Z doctors.
The board began offering sub-certification in neurotology in 2004, complex pediatric otolaryngology in 2021, and it became a co-sponsoring board of a sub-certification in sleep medicine in 2008.
So that's been a real benefit to the subspecialty of recognition, and also for the public to know that there is a standardization of the training.
And so that's the advantage of sub-certification. You provide a distinct service and have distinct skills, and therefore you need distinct certification.
To keep up with these new forms of certification and prepare for the future, the board added a full-time executive director position in 2004 and added staff in key strategic areas.
For the most part, all the people who participate in board activities that are on the physician level, they're volunteers. And so with all the expansion of what the board is doing, there's just no way we could do it without an established staff and a home office and an executive director who that's their full-time job.
The board's undergone a lot of change over the last 6 years, and with that change comes a lot more work.
The exam is 3 sessions of 3 protocols.
Meanwhile, the board modernized its governance. It freed up the directors to focus on the big picture, in part by including its dedicated volunteers in the construction of the exam.
The big work of the operations of the exam and the exam certification pieces, we restructure so that we have a larger inclusion of other people that can help us in that and bring the content expertise.
I don't think you would operate until the face is out completely.
And that we can tap into many people in our specialty, not just at the board level.
I think it's an interesting question.
By creating these new pathways to leadership, the board has also become more diverse than ever.
We are a very proactive group in making sure that we're not only representing our diplomates, but we are also representing our public.
I think if you look at the board members right now, it's one of the most diverse boards I've seen. Diversity in every way, right? Whether regional diversity, academic versus private practice, diversity with regards to specialization.
In 2020, the board would be faced with one of the most significant challenges in its 100-year history.
We were trying to keep our patients safe, our families safe, and ourselves safe. But in the process of doing that as members of the board, we also had to keep assessing.
The World Health Organization declared COVID-19 a pandemic 2 weeks before the scheduled oral exam.
And as we started getting closer and closer, we started getting more and more questions from candidates and also examiners of, is this really happening or not?
It's in hindsight, when you look at it, it seemed like it was so obvious the decision, that needed to be made, which was postponed. So that's when the decision was made. We need another plan.
We transitioned to this virtual exam, and I would say the staff and the team, really did an incredible job to pull that together.
The board delivered its first virtual exam in neurotology in December, and the primary certification 2 months later.
A completely virtual process, never been done before in our specialty. And for us to be able to pivot as quickly as we did, in that first examination, I was really nervous. I mean, what if the internet goes down? What if the computer crashes? What if these programs don't work? And everything ended up working so perfectly and smoothly.
I don't know that the thyroid situation is going to matter at this point.
Even before the pandemic, the board had started to refine the primary certification process to make it more rigorous than ever.
There's so much preparation, and you don't even appreciate that from the outside, but looking at the items, are the items correct? How are they going to perform? Standard setting, what is the cut score? There's so many layers.
And I think that's what you want from a safety standpoint.
We have subject matter experts who wrote the test. We have additional subject matter experts who review the test and make sure that it's consistent with the values and the purposes of the exam. And we also have psychometricians who can analyze the test and show, yeah, this question is valid.
In 2025, the board is taking a giant leap forward in its primary certification process with a complete redesign of the oral exam.
Really what we want to do is assess people in their practice. You have the physicians that are aspiring to be board certified physicians submit cases. You curate those cases, look at the cases, look at the patterns of practice that these individuals are exhibiting.
You're actually examining people on the decisions that they made about real people, talking about the operations that they did, what went well, what went poorly. If there was a complication, why would that have occurred, and could that be prevented?
If you get a complication, what do you tell the patient and their family? Are you truthful about it? And do you take responsibility for it? How do you care for them afterwards? So are they not only practicing competent medicine, are they practicing ethically?
Looking at how different it was compared to how...
On the eve of its 100th anniversary, the board unveiled its blueprint for the future. An ambitious strategic plan.
Healthcare is rapidly changing. And so we're kind of preparing for different scenarios that may happen. There's going to be a shortage of physicians expected. There's a lot more involvement of APPs. So I think it's trying to determine, with all these changes in healthcare, how are we going to make sure that the best healthcare is still being delivered?
What going through the whole process did for us is to say, you know what, we can be nimble. And we know if something unanticipated comes our way, that we have the processes in place to manage it.
As the board adapts to meet the new challenges of the future, one thing will remain a constant. It will continue to center the public in everything it does.
Board certification maintains quality, makes sure that we're held to a certain standard, but also the public knows that we took that extra step to be board certified. And so I think it gives our patients a sense of comfort.
Whenever there's a point of discussion that could be contentious or is a difficult decision, we always go back to Does this serve the public?
You may not always agree upon the length of an exam or the content of the exam or an exact question, but we can all agree that we want to serve our public the best we can.
I'm very proud of what our board does, and I'm proud of our board's relationship with both our diplomates and the public.